Mycobacterium leprae. This is a causative agent of the most dreadful disease, that is a leprosy, which was a very ancient disease. So this Mycobacterium leprae is an organism that causes leprosy, and leprosy has been a disease of the ancient time that has been recognized since the Vedic times in India and in biblical times in the Middle Ages. It probably originated in the tropic and has usually spread worldwide, and it was held to be as a superstitious dread, and the person who is suffering from this disease was thought to be an unclean person, and he was completely social outcast. And the lepra bacilli was the first human bacterial pathogen that causes the bacterial diseases that was discovered by Hansen in 1868. Though it was the first bacterial pathogen that was described, but less has been understood because of the inability of the organism to be grown on a cultural media. Coming to the morphology of the organism, this organism is straight or slightly curved, measuring about 1 to 8 micrometer in length and 0.2 to 2.5 micrometer in the diameter. Sometimes this organism expresses polar bodies or certain intercellular elements. And apart from this, the organism can express club-shaped and lateral buds are seen and a branching filamentous. It resembles a mycobacteria and it is similar to that of the mycelium of the fungi, and hence it is called as a fungus-like bacteria, similar to that of the Mycobacterium tuberculosis. These organisms are usually gram-positive in nature, and they can be stained with the help of acid-fast staining, and they uniformly stain in gram staining and also in acid-fast staining. They are not as acid-fast as the tubercle bacilli, as we have seen in the Mycobacterium tuberculosis. These organisms are strictly acid-fast in nature, and they do not get decolorized even after the treatment with 20% sulfuric acid or the dilute mineral acid. Here these organisms can easily be decolorized with 5% sulfuric acid. So once they are stained with the carbonylfuscin and application of the 5% mineral or dilute mineral acid or the sulfuric acid can decolorize this organism, and hence the acid-fast nature is not as tough as the Mycobacterium tuberculosis. There is a possibility of differentiating a live and dead organism under the smear. Live organism usually are solid and uniformly stained, whereas the dead organisms are fragmented and granular bacilli. The percentage of the organisms which are present in the bacterial lesion which are uniformly stained is called as a morphological index, and this is the index that helps us to know the progress of person's disease towards the chemotherapy. That is, it helps in assessing whether the person is on a chemotherapy, is showing a progress in the disease, or is towards the treatment side. So morphological index is mostly used to assess that in comparison to the bacterial index, which usually indicates the number of the bacilli in the lesion. So morphological index is the percentage of uniformly stained bacilli within a tissue section containing the organisms. And these organisms under the microscope are in the colony in the bacterial culture. They usually are single or in groups. They can be intracellular or extracellular, that is outside the cell, and they usually appear in masses because of a lipid-like substance which holds this organism together, which is called as a globi. And in the tissue section, they usually appear as cigar ends appearance, or in the staining purpose, these usually appear as a parallel rows appearing the cigar bundle appearance or the cigar shaped appearance, and in tissue sections we can see the cigar ends, and this helps in identifying the organisms under the microscopy. And this organism, that is a globi in the versus lepra cells, are usually foamy in nature, and they appear as large undifferentiated histiocytes. Coming to the cultivation, as already discussed, this organism is difficult to get cultivated into the bacteriological media that we use in the laboratory or in the tissue culture, and hence less characteristics of this organism have been understood. There are many scientists and there are many institutes that have come forward to propose that they have successfully isolated the organism in the culture, but they have not yet been confirmed. Similar type of research came from Indian Cancer Research Center, Bombay, where they have suggested they have isolated an acid-fast bacilli from the lesions of a leprosy patient, and they have grown this bacilli in a human fetal spinal ganglion cell culture. And but there is no relevance, or there is no there are no reports to confirm that this is a lepra bacilli. But they have isolated the bacilli and they have named it as ICRC bacilli. And this organism that was isolated by ICRC was adapted to grow in Levenstein-Jensen's medium. There are many successful attempts that were carried out to transmit the infection to the animals, and the real breakthrough was given by the shepherd, who was able to cultivate this organism in the foot pad of the mice. Following intradermal injection of this lepra bacilli, the guinea pig has shown the lesion at the site of inoculation, and when the cell-mediated immunity was eliminated by thymectomy or by anti-lymphocyte serum, they could see a generalized infection caused by the lepra bacilli, showing or progressing the disease towards the lepromatous leprosy. And this was the standard procedure that has been used since then to isolate or to grow the organism in the experimental animal. And the immunity that comes forward during this response is the cell-mediated immunity. So once there is a loss of cell-mediated immunity, you can see the organism progressing into the disease, that is causation of the disease towards the lepromatous leprosy. And it is suggested that a 9-banded armadillo, that is the Dasypus novamcintus, is more susceptible to leprosy and shows a generalized lesion of lepromatous leprosy. The generation time of this organism is very long in comparison to the other bacteria. It takes about 12 to 13 days to grow on a media, and it can range up to 8 to 42 days also. So in comparison to Mycobacterium tuberculosis, which has a generation time of 14 hours, this organism is the one which has the longest time of generation time, and incubation period of this organism is also very long, that is it takes years to show its symptoms. And the natural infections are usually seen in the chimpanzees and Mangabe monkeys, and there is no relevance to show that they are in similarity with the human leprosy. And Mycobacterium leprae genome have been mapped, and the protein involved in the antigenic character have been sequenced. Coming to the resistance of this organism, these organisms can be viable in the humid environment for about 9 to 16 days. They can survive in the moist soil for about 46 days, and the survival exposure towards the sun is about 2 hours, and they can survive in ultraviolet rays for 30 minutes. Coming to the disease, that is the leprosy, as already discussed, this is an ancient disease, and it is characterized by the chronic granulomatous disease of the human. And the most important part that is involved in the lesion formation is the skin, peripheral nerves, and the nasal mucosa. The disease has been classified into 4 different types, that is lepromatous, tuberculite, dimorphous, indeterminate leprosy, which was classified by Madrid and it is called as a Madrid classification. Now, the type of the leprosy that a person develops depends upon the immune status of his body, or the immune status of the host determines which type of leprosy is usually caused among the 4 different types, and also based upon the chemotherapy that a person is usually upon. So based upon the chemotherapy, there is a change in the resistance of the human immune system, as a result of which the person can land up up to any type of the 4 different types of leprosy. The two extreme polar forms, or the two extreme forms of the polar forms of leprosy among the 4 is the lepromatous leprosy and the tuberculate leprosy. So coming to the lepromatous leprosy, this is seen in the individual who has the immune resistance as very low, where the person is suffering from any immunodeficiency disease, or when there is a low immune status in a person, in that person you can see the causation of the lepromatous leprosy. And here in the case of this particular patients, the globi are usually present in large number, and more number of bacilli are present in the form of a globi. They can be external or internal, and due to the presence of large number of this organism, it is called as a multibacillary disease. And the characteristic feature of this multibacillary disease or lepromatous leprosy is the formation of a lepratoma. Lepratoma is a superficial nodular lesion which is characterized by the granulation of the tissues within which they contains a dense number of vacuolated cells, having cells in different stages of development, ranging from the monocytes to the leprabacilli, that is containing in the vacuolated cells. And this characteristic lesion is due to the decrease in the cell mediated immunity. Here the nodules can ulcerate and can lead to the formation of the ulcerated nodules, which is a characteristic feature of the lepromatous leprosy. And the infection is usually secondarily and can lead to distortion and the mutilations. The mucosa of the nose, mouth and respiratory tract are mostly involved in this particular disease. Apart from that, reticular endothelial cells or reticular cells of the eyes, testes, bones and kidneys can also be involved. Basilemia is common in this particular disease, and the prognosis is poor. And this is the most common type of leprosy that can be seen in the individual who has immune status which is very weak. And the cell-mediated immunity is inadequate when comparison to the tuberculate leprosy. The cell-mediated immunity is very less, and hence there is no delayed type of hypersensitivity reaction that can be seen in the tuberculate leprosy. And due to this, the person usually shows negative towards the lepromin test. He is negative for a lepromin test, and the humoral immune response is exaggerated in this particular condition, where you can see activation of the polyclonal B cells, and more amount of antibodies are produced. So high titer of antibodies can be seen in this particular disease, though they are not useful for the production of the disease, but you can see a high number of the antibodies or a high titer of the antibodies. Apart from that, antibodies are also common, and during this particular infection, they give a biological false positive test for the serological test for syphilis. Now coming to the tuberculate leprosy, here the person who show a high degree of resistance towards the diseases are usually affected by this tuberculate leprosy, in comparison to the lepromatous leprosy, where the immune status, the person with low immune status usually develops the lepromatous leprosy. Here in the case of tuberculate leprosy, it is the person with high degree of resistance that can land up to tuberculate leprosy. And here the lesions are sharply demarcated, and they are usually characterized by macular and anesthetic patches. The neural environment is usually early in nature and progresses for a prolonged period of time, leading to the deformities of the hands and the feet. Bacilli in this condition are scanty in comparison to the lepromatous, where you can see more amount of bacilli, and hence that disease was called as multibacillary disease. Now because the bacilli in the lesions are scanty in nature, this tuberculate leprosy is called as a paucibacillary disease. Cell mediated immunity is adequate in nature, and hence you can see a delayed type of hypersensitivity reaction along with the lepromin positive test. And there is no involvement of humoral immunity, and antibodies are not produced against antimicrobial antigens, and there is no production of autoimmune antibodies. And here in the case of tuberculate leprosy, the prognosis is very good when comparison to the lepromatous leprosy, where the prognosis is very poor. Now coming to the third type, that is a borderline or the dimorphous. Here the lesions that are produced during the disease are intermediate between the lepromatous leprosy and the tuberculous leprosy. And depending upon the chemotherapy the person is on, the lesion can shift either to the lepromatous leprosy lesions or the tuberculous leprosy lesions. Now the last one is the indeterminate type. Here there is an early unstable tissue reactions, and the lesions that are formed do not resemble the lepromatous leprosy lesions or the tuberculous leprosy lesions. And based upon the immune status again and the chemotherapy, the lesion can either progress to the lepromatous or the tuberculous leprosy. But here it is the lesion that are seen in indeterminate is completely different from that of the lepromatous leprosy and the tuberculous leprosy. Apart from all these four classification, Indian system has again classified another type of leprosy which is called as a pure neurotic type of leprosy. Here in the case of pure neurotic type, there is no bacterial involvement and there are no skin lesions, but complete neural involvement is there. And next is the Ridley and Joplin classification. They have given a scale for the spectrum of infection that is caused during the leprosy. So they have graded this based upon the type of leprosy that a person is suffering. So that is a scale that helps us to know at which stage he is and what is the type of lesion that he is usually expressing. So this leprosy can be classified into 5 different types based upon the Ridley and the Joplin system. So first is a tuberculite that is usually expressed as capital TT, borderline tuberculosis BT, and then we have borderline BB, and next fourth one is a borderline lepromatous BL, and the last one is a lepromatous, that is the extreme case LL. So this is how they have graded the scale of the leprosy and a spectrum of the lesions that are usually formed during this particular infection. Now coming to the epidemiology, as we know that this is a very ancient disease and it is exclusive human disease that can be caused only to the humans, and the source of the infection is the patient itself, and the mode of infection is not clear. But because the organism is carried in the patient in the nasal mucosa, it is said that the patient can transmit about 8 to 10 to the power of 8 bacilli in a nasal blow, and the mode of entry is the skin or the respiratory tract, and sometimes asymptomatic infection can also be seen in the endemic areas, where the asymptomatic patient are able to transmit the infections to the one who is in close contact with that person. And there are suggestions that insect vectors sometimes can transmit the infection, but no such possible reports have come forward. But it is said that mosquitoes are able to transmit the infection to the guinea pigs or the rats, but not to the human beings. This disease is not communicable as we see in the other diseases, and the reason is there is a close contact. Only when there is a close contact you can see the person landing up to this disease, and it is not highly communicable when compared to the others. And the disease is caused only in 5% of the spouses who is in contact with the leprosy patient. The incubation period is in the years, as already discussed. It has a longer generation time as also the incubation period. So the incubation period is about 2 to 5 years. It can range from few months to 30 years too. And the intimate close contact is necessary for the transmission of the infection, and a single shot of tattooing can also transmit the infection. Mostly this disease was thought to be a worldwide disease initially, which has now come down and is seen only in the underdeveloping countries. The reason behind this is because of the many control programs, social awareness that came forward and helped in the elimination of the disease. So there was a drastic decrease in the cases of the leprosy patients from 15 millions to 3 millions, and this disease is only seen in the southern hemisphere, including the Southeast Asia and the Brazil, which are mostly affected with this disease. Now coming to the India contributes about 1/3 of these diseases of the global total, and mostly the disease is seen in an area of Orissa and Bihar, where the Haryana shows the least number of patients when compared to the other states of the India. Now coming to the immunity that usually comes forward to protect against this disease in an individual. Both innate and adaptive immunity is essential to protect the from the diseases. So innate immunity helps in elimination of the organism because the organism enters via the skin or the respiratory tract. They act as a first barriers to eliminate the infections. Next comes the adaptive immunity. In the case of leprosy, both the humoral as well as the cell-mediated immunity usually comes forward to eliminate. But cell-mediated immunity is the one that usually fights against the organism and eliminates the organism in comparison to the humoral immunity that do not show a protective immunity. And depending upon the type of immune status of a person, as already discussed, the lesion can either be a tuberculite or the lepromatous. So in the case of the person with adequate cell-mediated immunity, the person showed tuberculite lesions and showing delayed type of hypersensitivity reactions. Here in the case of the tuberculite lesions or the tuberculite leprosy, the cell-mediated immunity usually activates the macrophages. The macrophages come forwards to eliminate the organism. That is, they engulf the organism and eliminates the organism. And specific humoral antibodies are usually not produced in much amount, and hence there is no change in the albumin and the globulin ratio in case of tuberculite leprosy. Now coming to the lepromatous, as there is an inadequate cell-mediated immunity due to low host resistance or immune resistance, it can lead to lepromatous disease. And here because there is no active cell-mediated immunity involved, the delayed type of hypersensitivity is also absent. And cell-mediated immunity though activates the macrophages engulfs the organism, but the organism will have the ability to proliferate inside the macrophages. And this show lepromin negative test, and the cells that usually comes forward during the lepromatous leprosy is the CD8 lymphocytes, or the lymphocytes that are present in the lesions to fight against the lepra bacilli are the CD8 types, in contrast to the tuberculite where they have the CD4 plus type of T helper cells. And the lepromatous leprosy, there is an activation of polyclonal B cells, and hence there is a high titer of antibodies that usually reverses the ratio of albumin and globulin. And antibodies are produced against the antimicrobial antigens that are present on the bacilli. And the production of the disease, whether it is a tuberculite or the lepromatous, completely depends upon the genetic effect of an individual. The person with the human leukocyte antigen DR2 usually develops tuberculite leprosy, and the person with human leukocyte antigen MT1 and HLA-DQ1 are most prone to lepromatous leprosy. And though it is a chronic disease, there is an interspread acute exacerbation of the lesions leading to the type of allergic reactions. There are two types of allergic reaction that can be seen. Type 1, also called as a reversal reaction or the lepra bacilli, which usually seen in the borderline leprosy that occurs spontaneously or due to the person on a certain chemotherapeutic agent. Here the cell-mediated immunity reaction is active, and lymphocytes are usually of the are present inside the lesions of the tuberculite. And the characteristic feature of this is the lesions show erythema, swelling, pain and tenderness, and same type of clinical picture is also seen in the downgrading reaction in the patients who are untreated or who are pregnant women. When there is a biopsy that is done of the lesion, there is a shift from the tuberculite to the lepromatous lesions, so reflecting that there is a decrease in the cellular mediated immunity. Next type of allergic reaction is a type 2, also called as erythema nodosum leprosum, which is characteristic feature of the lepromatous leprosy or the borderline leprosy, and it is seen in the individual who are based upon their therapeutic agent. Once a patient is treated by the antibiotics or the chemotherapeutic agent, these people are more prone to develop this erythema nodosum leprosum, and they are characterized by the crops of tenderness, inflamed subcutaneous nodules, which are in combination with fever, lymphadenopathy and arthralgia. And this type of people expresses aphthous type of reaction towards the antigen of the dead lepra bacilli. Because of this aphthous type of reaction, you can characterize it with the neutrophil infiltration, IgG accumulation, and the complement deposition. So it is because of all these three important lymphocytes that are produced during lepromatous leprosy, you can see aphthous type of reaction. Now coming to the test that is used to identify this disease. So initially it was the lepromin test that we are using to identify the disease in an individual. So it is similar to that of the tuberculin test that was used to identify the tuberculosis, which is a serological procedure, that is a Montax test. But here in the case of lepromin is the antigen of the organism that is mostly used to identify the disease in the individual. So the skin test is called as a delayed type of hypersensitivity reaction towards the lepromin, which is present in the organism. The lepromin is usually boiled and emulsified lepromin bacilli contained in a lesion, and they are injected on the flexiform of the forearm and seen for the reaction. So the lepromin test is said to be biphasic in nature. Usually the initial phase that is recognized is within 24 to 48 hours, which an indurated lesion, and that can last up to 3 to 5 days. It is called as a Fernandez reaction. It does not give a much clinical importance, or it is not very much used in the diagnostic procedure. It is a late Mitsurza reaction that helps in identifying the leprosy test. So the late Mitsurza test is because of the granuloma that is formed after 2 to 5 weeks of the injection of the lepromin inside the body. So here there is a giant cell that is formed due to the accumulation of the lymphocytes and the other infiltration of the other immune cells. So that gives a positive reaction, that is a Mitsurza late reaction that helps in identifying the disease. But it is not said that this particular lepromin test helps in identifying the person with the leprosy. It can also give a positive reaction in the patient in an untreated or in an endemic area who is not suffering from that disease. But this particular test, lepromin test, is mostly used to identify the type of reaction, whether it is a lepromatous or the tuberculoid. Helps in the prognosis, helps in identifying the resistance of the patient towards the disease. So it is not used to identify the leprosy, but it is used to classify, and for the prognosis purpose we can use the lepromin test. Lab diagnosis, here the bacterial diagnosis, that is identification of the bacteria in the lesion, is the only method to identify the disease, and the organism is usually isolated in the smear, and acid-fast staining is usually done. So it is the acid-fast staining with a 5% sulfuric acid that acts as a decolorizing agent that can be used to identify the organism. Coming to the specimen can be collected from the nasal lesions or the earlobes, and the specimen that is collected from the nasal is with the help of a blunt narrow scalpel, which is inserted into the nose, and part of the mucous membrane usually taken out, scraped off, and then put on a slide and slightly teased and uniformly stained with the acid-fast staining. Now in case of the lesions which are present on the skin, with the help of a scalpel, a 5 mm cut is made, and the blood and the lymph are usually eliminated, and later on the same cut is usually done in a transverse section to remove the outer part of the lesion till it reaches the tissue pulp. Now the tissue pulp will usually harbor the organism. The tissue pulp is taken and done with the acid-fast staining. Now this acid-fast staining is done similar to that of the acid-fast staining of the Mycobacterium tuberculosis. Here the primary stain is a carbon fustian, after which it is decolorized by using 5% dilute mineral acid or the sulfuric acid, and then counterstained with any of the methylene blue or the picric acid or the any other secondary stains. So here the organism again looks like the red color, and this is a positive test for the identification of the organism. And sometimes in case of the involvement of the arteries or the lymph node, then you can go with the biopsy also. Now, once the staining is done, the smears are usually graded to identify the number of organisms that are present, and similar to that of the tuberculosis, the immediate report should not be given until and unless 300 fields have been studied. So here the grading is done as 1 to 10 bacilli in 100 field as 1, 1 to 10 bacilli in 10 field as 2 plus, 1 to 10 bacilli in per field as 3 plus, 10 to 100 bacilli per field as 4 plus, and 100 to 1000 bacilli per field as 5 plus, and more than 1000 as 6 plus. So this is a grading that is usually done to identify the organism under the microscope and grade the number of the organism. So this in turn is expressed as the bacteriological index, that is the number of pluses, that is the bacteria present pluses divided by the number of smears. Suppose if we are taking 8 different smears containing 16 pluses of bacteria, this indicates that the bacteriological index is 2. And instead of bacteriological index, we can go for the morphological index, that is the percentage of uniformly stained bacilli with the total number of the bacilli that have been found. So morphological index is used in the diagnosis or identifying the lepra bacilli. Now next is the inoculation of the organism into the experimental animal. As described by the shepherd, this organism can easily multiply in the mouse foot pad, but this particular technique is not used to grow the organism in the animals, but to test the drug potency and the resistance of a person towards the disease, etc. So mouse foot pad inoculation is not done to isolate the organism. Next, more sophisticated techniques that can be used is to detect the antibodies, because there is an increase in the antibodies in the lepromatous lepracy, and the antibodies are produced towards the mycobacterium leprae antigen phenolic glycolipid antigen. So this can also be taken as a diagnostic tool to identify the infections. Molecular techniques are still in use, and they are in progress to identify the disease. But only thing that helps us to identify the organism in the lab is the demonstration of the bacilli in the lesions and the histology of the lesions. Now coming to the treatment, the only treatment that was given for this leprosy was the dapsone, and it was a monotherapy because dapsone was said to be highly susceptible towards the organism and kill most of the organism. That was the only drug of choice used to eliminate the infection. But because the organism has developed resistance towards the dapsone, so multiple drug therapy has to be given. So depending upon whether it is a multibacillary disease or a lepromatous disease or a paucibacillary disease or tubercular disease, you can change the dosage of the different antibiotics. The most prescribed one is a rifampicin, 600 mg per month in case of paucibacillary disease, along with the 100 mg of the dapsone daily for 6 months. Now in coming to the multibacillary disease, the same dosage of rifampicin 600 mg is given once a month, and dapsone 100 mg daily, along with cloflaxacin 500 mg daily. So this is a bactericidal antibiotics that has to be combined with bacteriostatic antibiotics, that is the ethambutanol or prothionamide or cloflaxacin. And a follow-up should be done for both the paucillary and the multibacillary disease till we get a negative result in the smears. So for 4 years follow-up should be done for the paucibacillary disease and 8 years for the multibacillary disease. Now there are different scientists that came forward to produce a vaccine against this particular disease, but none have been successful yet. There is one vaccine that was proposed by National Institute of Immunology, New Delhi, that usually enhances the multiple drug therapy when given along with the multiple drug therapy. Alone, the vaccine is not helpful in eliminating the infection or the prevention of the infection. Now coming to the prophylaxis or the control of the disease, case finding, that is you have to find the person who is suffering from this disease, and then adequate therapy should be given so that he is no longer able to transmit the infection, and long-term chemotherapy is successful in nature to eliminate the infection in the young children. And now since there is an antigenic relationship between the Mycobacterium tuberculosis and Mycobacterium leprae, BCG can be given as a prophylactic treatment to prevent particular leprosy disease. But when the control trials were carried out, they showed variation in the results. Some shows a protective 100% or a 10% protective role, whereas some did not show any type of effect with the BCG. And the prescription of the BCG was usually given by the Fernandez. Now, field trials have been done to eliminate the infection with the combination of 3 types of vaccine. One is a BCG, next is along with the killed lepra bacilli with ICRC bacilli. So this 3 combination vaccine have been produced, and still the attempts are being tried to eliminate the disease with the help of this particular vaccine. Now, coming to another important group of organism, that is Mycobacterium leprae murium. This is the organism exclusively which causes infection in the rat, and it is called as a rat lepracy. It was discovered by Stefanski at Institute of Edesse, and the characteristic feature of this particular disease is it causes subcutaneous indurations, lymph adenopathy, emaciation, ulceration, loss of hair. And acid-fast bacilli are usually seen in the lesions, and there is no nervous or neural involvement in this particular disease. And this Mycobacterium leprae and Mycobacterium murium are they do not show any type of relationship when the DNA analysis was done. So this is about Mycobacterium lepracy.